So chronic pain does more than just hurt. That's a line that I use a lot. What we know in the chronic pain patient is that there's actually rewiring in the signals that go from the area of pain up to the brain. And they've done studies to verify this. So we would anticipate when we look at the brain of a chronic pain patient that a lot of activity is going on in the pain center. And that happens. That's absolutely true. But there's also a similar increase in the amount of activity that goes on in the mood, function, behavior, decision-making sections of the brain as well. So when we manage pain, we can't just say, if we get rid of the feeling of pain, everything else will get better. We have to treat the biological, the psychological, social, and functional aspects of pain. And that's where multidisciplinary pain management comes in.
Welcome to the Exercise is Health podcast, where we're talking about exercise, health, and the interconnectedness of the two. We are your hosts, Charlie
and Julie,
and we will be coming to you every single week from our studio, Muscle Activation Schaumburg. Hey, welcome back, everybody, to the Exercise is Health podcast. We're your hosts, Charlie
and Julie,
and we are coming to you from our studio, Muscle Activation Schaumburg in Schaumburg, Illinois. Now, at Muscle Activation Schaumburg, we believe that your health is your most valuable asset. Your health is one of the biggest influencers of the quality and quantity of time that you have. And while there are many aspects of health, our expertise is exercise. Exercise has been proven time and again to not only improve your health, but also increase your longevity and improve your quality of life. But we know that exercise is not the only piece of the puzzle, and why we are bringing you a phenomenal guest today, none other than Dr. Ankur Dave. Dr. Dave specializes in pain management and anesthesiology and collaborates with a multidisciplinary team of specialists, including pain psychologists and physical therapists, to maximize patient outcomes. He has affiliations within the Amita Health Alexian Brothers system, including offices in Elk Grove Village, Hoffman Estates, Hinsdale, LaGrange, and Bolingbrook. Dr. Dave, thank you so much for joining us and welcome to our show.
Thanks for having me.
Absolutely. So, Dr. Dave, tell our listeners more about your educational background, your personal background. How'd you get into medicine, and how'd you get into pain management of all things?
I'm an interventional pain management specialist, and currently I serve as the medical director for the comprehensive pain management program at Amita Health. Before that, in terms of my training, I completed my residency in anesthesiology at Rush University Medical Center. Before that, I did my undergrad and medical school training at St. Louis University down in Missouri. And really, in my medical school and residency days, that's when I started developing an interest in chronic pain. The main reason back then that I was so interested with chronic pain was that I found it to be a very challenging condition for both the patients as well as providers to better manage. And the big reason for that was the subjective nature that surrounds chronic pain. When you have a condition like diabetes or high blood pressure, there's more or less a treatment plan that's based on objective findings, such as high blood sugar or high blood pressure, and that's what's monitored throughout the whole treatment plan. With chronic pain, it's different. With chronic pain, there's a subjective nature to the pain. It's about how a patient feels. It's about what a patient can or cannot do. And that's what brings the biggest challenges about it. So as I went through my residency training, I got more and more interested in this topic. So I completed my fellowship training out in Boston at the Brigham and Women's Hospital, which is a Harvard Medical School hospital. And after that, I came back to Chicago and started practicing. And my focus has always been on comprehensive pain management and really focusing on what, improving not just the physical aspect of pain, but also the biopsychosocial aspects of pain too. I would say that, over the past couple of years, what really has really driven my passion in the field is helping to better manage the opioid epidemic. Because that's, it's affecting so many people and so many aspects of healthcare, and it's really it's morphed into a public health phenomenon. and it demands the attention of all specialties. Pain management, for instance, we become vital to help curb the over-reliance on opioid medications and drive more innovative and evidence-based treatment modalities that help patients better manage their chronic pain outside of just pills.
Yeah, that's interesting. I want to jump back to one of the first things you said about chronic pain that I actually had written down and I didn't give you in our little pre-notes chat. You mentioned that the chronic pain issue is a subjective thing, which brings this piece of challenge that actually kind of drew you into the modality or the specialty. How do you assess someone for chronic pain then if you can't look for markers in someone's vitals or their blood? How are you able to, or how do you guys assess and figure out what someone's going through? Is it just through like a verbal conversation? And what modalities do you use to do this kind of assessment?
So, the field of, I guess taking a step back from that, because that's a really great question, the way we used to manage chronic pain is now undergoing a transformation. And we're trying to figure out what the best ways to monitor and track chronic pain in patients. The old way of measuring pain was simply based off a number. So you tell your physician or your healthcare team, on a scale of 0 to 10, how bad is your pain? Mm-hmm. There was no real defining, like what defines a 10, what defines a 0. Every patient's experience of 0 to 10 is different as well. If I, stub my toe, I may rate that as a different number than you, Julie, or you, Charlie. So as on the healthcare side, a 5 for one person means different than a 5 for another person. And that's been the biggest challenge in terms of objectifying pain. When it comes to the treatment side of it, we know that in the past, managing chronic pain was more or less the same as managing acute pain, meaning the treatment plan for managing a bone fracture was the same for the week after the bone fracture, as well as people that have had chronic low back pain for 10 years. And it was because, for many reasons, but one of the reasons was, when the patient goes into the clinic, what's your pain score today? Well, if it's a 7, then a 7 means this medication. Oh, a 5? Well, that means it's this another medication. And our focus now has become more about therapy-focused goals. So what are you now able to do functionality-wise that you were not able to do before a certain intervention or before the pain started? And that's been our focus. So the way I try to attempt that is on a patient's first visit, discuss the things that they're now not able to do because of their chronic pain. Are they not able to walk their dog around the block? Are they no longer able to run a certain amount of distance? And set that as the goal for their treatment.
How do patients perceive that shift? I don't know if when you began practicing, if you kind of said in the beginning, you used to do like this number scale, and now it's more of the functionality of what can you do, what can you not do, what can we help you start to do again. Did you see a shift in how patients respond to that kind of conversation? Because it is a very different type of conversation of, how's your pain? Give me a number versus what can you not do and how can we figure out a path or a plan to help you do this? Do you get pretty good positive responses from that, or does it kind of catch people off guard?
I think right now it catches people off guard because there's still the traditional way of practicing for many providers. Many providers are still using that pain score. So when a patient comes to our center and they are asked, yes, they're asked the pain score, but they're asked a battery of other questions that are focused on what are their physical and emotional functioning and what the physical and emotional loss of function is. Many patients respond positively to it because, what we hear a lot is, oh, I've never been asked that before. Or, I'd really love if I was able to do this. And once the patient says it out loud, I think they realize that it becomes a goal at that point. And I think most people, when they see a goal, that it drives them towards that goal. And then after any sort of, whether it be an injection or physical therapy or seeing the health psychologist, they're able to identify that. They say, hey, now I could go do that. And I think patients appreciate that more than saying, oh, now I'm trying to decrease my pain from a 7 to a 4, because there's no end game with a 4 out of 10. There's no real definition behind it.
Hey, Dr. Dava, I mean, I have to completely agree, and I mean, I'm really happy that you're saying all the things that you are, because I think, at least in our practice here, that's a very similar experience to what we have with our clients. Our practice is not set up by any means to address somebody's pain, but people come in and they have certain aches and things that are uncomfortable, and so over the course of working with them, having these objective physical goals that they can go after versus, like you're saying, reducing the pain sensation from a 7 to a 4, as you gave the example, it seems to be that there's such greater buy-in with the whole process with that. Yes, people want to feel good, absolutely, but to your point, hey, having some objective markers to hit along the way can really help fuel that process. So since you've been implementing that, and since you've been exposed to that and started implementing that, is that what you have noticed, that there's this kind of greater buy-in once the idea gets presented and the patients get excited about it? Do you find that there's a greater buy-in over the long term versus just trying to reduce a number score?
I think for a lot of patients, yes. I think there's still some patients that aren't ready for that at this point in how they understand the condition. Those patients will typically require a little bit different approach when we talk about managing with pain psychology, or focusing more on the medical aspects of pain until we're able to transition them over to more therapy-focused goals. The patients that understand therapy-focused goals, they are a lot happier as they see progress. And they also have a better sense of what is tolerable and what is not tolerable. I have a subset of patients that come in that, for lack of a better term, they have unrealistic expectations. They may be in their 60s and they're expecting to feel like they're in their 20s, or they may have a problem with obesity and not really fully comprehend how that obesity is affecting their chronic pain. So, even the best injection in the world is not going to make that pain completely go away. But the patients that understand that, hey, I might be a little bit older, so I still battle aches and pains, but if I have these things that I'm able to do, let's say enjoying time with my grandkids, then I can deal with those aches and pains because I hit that goal that I really, really wanted.
Yeah, that's awesome. And that's something really cool that we've noticed in our practice as well. When individuals are getting stronger, and let's say maybe they have arthritis in their knee, they can do so much more stuff, garden, get up and down off the ground, walk upstairs, and not have as many negative repercussions. So that's probably a combination of, hey, their body physically is more able, but also, like you said, their their ability to tolerate things increases. That's really cool that you've noticed that. You mentioned in the beginning, and the way you're discussing this, it's kind of alluding to this. So I hope we can dive a little bit more into this. You said that you guys do a multidisciplinary pain management plans. I believe those were the words, something like that. What does that mean? What are the different disciplinary areas that you guys are looking at when someone's coming in with chronic pain?
So chronic pain does more than just hurt. That's a line that I use a lot. What we know in the chronic pain patient is that there's actually rewiring in the signals that go from the area of pain up to the brain. And they've done studies to verify this. So we would anticipate, when we look at the brain of a chronic pain patient, that a lot of activity is going on in the pain center. And that happens. That's absolutely true. But there's also a similar increase in the amount of activity that goes on in the mood, function, behavior, decision-making sections of the brain as well. So when we manage pain, we can't just say, if we get rid of the feeling of pain, everything else will get better. We have to treat the biological, the psychological, social, and functional aspects of pain. And that's where multidisciplinary pain management comes in. So that's we really look at it as a 5-pronged approach. So there's the physical aspect of pain, and that requires exercise as well, whether that be guided through a physical therapist or even home exercises to at least get started. Then we talk about the integrative approach, so that's number 2. The most common examples of integrative approach that I talk to patients about is yoga and mindfulness, because these have very good data for helping patients cope with chronic pain. Then we talk about the behavioral aspect, and that's pain psychology. There's a modality called cognitive behavioral therapy, which goes to coping with chronic pain and kind of understanding how pain affects the mind and body, and attempt to break that line between mind and body, so the mind isn't held handicapped by the brain. And then the 4th approach, procedural. So now we're getting into the more medical interventions. Procedures can be something as simple as ice, heat, kinesio tape. They can be more advanced, such as injections, minimally invasive procedures. Or for some patients, they do need surgery, so it's optimizing them for surgery. And then the 5th prong is medication. So that's the medication management, trying to optimize patients for the long run with medication. So not treating a pill as 6 hours at a time, or as saying that, okay, we're going to manage your chronic pain 4 to 6 hours at a time with this pill, but really taking a step back and saying, how do these medications help your body? How do they work in conjunction with the other modalities, and how safe are they for long-term use? And altogether, that combines simple multidisciplinary care.
That's amazing. And so on your staff, or part of the staff that you're on, there's professionals that cover each of those 5 categories, correct?
More or less. It's tough to get that access to all patients. It's just the healthcare system is not set up in its current way to really get patients as efficient care as they need to.
Mm-hmm.
What we've developed at AMITA is, I think, as close as that can come in the community. So we have health psychologists that are in our clinic. We have surgeons that, for the surgical side of chronic pain, so surgeons that we work very closely with. Pain management side, I'm there, as well as 2 other pain physicians, Dr. Schmidt and Dr. Patel. And we also have very close ties to numerous physical therapists, and all of us work together. And we also have weight loss management and nutritionists that are very, very closely aligned with us at AMITA Health. So it may not all be at one location on one day, but we can easily get patients into those resources that they need.
That's awesome. So when a patient comes in, do they kind of run through, because you list off physical, integrative, psychological, procedural, and then medication. And were those listed like as they came to your head, or were they listed in a specific order? I'm just looking at is it almost like less invasive to more invasive? Is that kind of the path that a typical patient will go through, like starting with the physical and then going all the way to maybe the procedural or medication? Or do multiple get implemented at once?
Multiple get implemented at once. We try to stay away from an algorithm for everyone.
Mm-hmm.
So different people are at different emotional states of their pain. So some people don't need health psychology, and they really should focus on the physical aspect. Other patients, if they go to a physical therapist right now, or if they're in a group exercise program, they're really not going to do well.
Mm-hmm.
And they need more of that medical aspect, or they need help with injections or something like that. So it's, we always prefer moving from the most conservative to least conservative. The reason I came up with, I mentioned it in that order, is honestly when I give presentations, that's the diagram that I use. It goes in that order. So
that works great. And so what might be some indications, or what are things that are being measured or tested for to try to determine whether or not somebody needs to go to the medication or the psychological route or the integrative route, or one of the other two right away? Are there certain markers?
So yes, the ideal way is to really manage and figure out what is the best approach to patients with chronic pain is through a history and physical exam. So really sitting down and understanding how the patient feels about their pain and how they're actively coping with their pain and what they've done for it already. If a patient has undergone a certain type of injection and it hasn't worked, well, there's no point doing that again. But there's also objective measures. So, understanding when they went to the physical therapist, what were their baseline range of motions. We also utilize questionnaires such as the PHQ-9, which looks for depression, the SOAP score, which assesses how they're taking their medications for certain types of medications. So, it's a whole bunch of things that combine together that we then talk about with patients and see what they're ready for and what they're not ready for. The other aspect that we really value is patient input, right? So we'll talk to them about these 5 prongs and we'll get a sense of what they're ready to buy into right now and when they'll be ready to buy into the rest of it later.
Cool.
Yeah, interesting. As you're talking about, these steps and different avenues that you guys take to address and help manage people's chronic pain, can we talk a little bit more about what do these people look like? Like, are all these people have a mysterious pain that they've just had for a long time? Or are people coming in with pain that is associated with another chronic ailment that maybe they have a diagnosis for? Can you tell us about the people that are actually involved in this program and that benefit from this kind of a program?
So 2 of the most common reasons that patients go to see a physician to begin with is chronic low back pain and chronic neck pain. So, and for many patients, chronic pain itself is defined as pain that's been going on for greater than 3 months or beyond the time of normal tissue healing. So we used to think, okay, well, a patient had a motor vehicle accident 20 years ago and this pain has just followed them for 20 years. But many people have motor vehicle accidents and they don't have symptoms. So what makes some patients prone to chronic pain, what makes some patients not prone to chronic pain? That's where a lot of research is going into. But more or less, when we try to figure out what the best approach is to chronic pain, it's about identifying what the source is. So is it a muscle issue? Is it a disc issue? Is it a nerve issue? Is it a bone issue? And figuring out, is there an active problem right now as to where an injection needs to be done or surgery needs to be done? Or is this something that a patient's had for a long time and the body just can't get over the hump in terms of it's how patients feel about it? Ultimately, if a patient had a motor vehicle accident 20 years ago and they still have pain, does it really matter what the cause was? What really should matter is how the patient has been doing for 20 years and why the pain stuck around for 20 years.
So the patients that are enrolling and or really benefit from this kind of care, do they ever also have other diagnoses? I mean, you mentioned like a vehicle accident or, bone problem or muscle problem, but are individuals usually struggling with more than one thing when they're going through this? Or is it usually just, I've got this one pain area that has just not healed in normal tissue healing time?
I think most chronic pain patients have, for instance, for low back pain, what we know is the most common conditions is a disc in the spine that's degenerated and maybe pinching on a nerve. And so those patients will have pain that is quite distinctive in terms of having back pain, but it also radiates down the leg. And these patients might also have arthritis in the back as well. Because chronic pain it's not just one thing that causes chronic pain. It could be a mix of 2 to 3 different conditions. Mm-hmm. So if they have arthritis as well as a bad disc, they may be suffering from 2 different causes, but they're not able to identify which one is the one that's causing most of my symptoms. On the converse, we may treat the disc, maybe we do an injection that helps for that pinched nerve, but the patient comes back and says, well, the pain going down my leg is better, but the low back pain is still there. So, figuring out the percentages or what percentage of pain is from the disc, what percentage of pain is from the arthritis. That's probably the most common is patients that have 2, maybe 3 things going on, but they're all still overlapping in terms of how patients feel about it.
Hey, Dr. Dave, what are some influencers of how well a patient does within the program? Because I'm guessing that not every single patient progresses along at the exact same rate. There are some patients that do really, really well, and there are others that maybe struggle a little bit more. What have you seen as far as things that either they do or like have done earlier in their life that are now catching up with them that seem to kind of influence the results that they get?
I think patients that have lived healthier lifestyles in general over the course of their lives, they typically are able to cope with chronic pain better and understand limitations better. So those patients don't necessarily need to use all 5 prongs because they already know, whether they know the official treatment modality for it or not, but they know how to cope with pain. They're already using mindfulness, they just don't know that that's what it's called. So those patients typically, their chronic pain is much better controlled. They do a lot better in the program. Other patients are those who utilize lifestyle modifications. So they're eating healthier since the chronic pain started. They've started to lose weight. They've started to exercise. Those patients, by the time they come to see me, if they've already started doing that, typically they respond better. Patients that don't respond as well are patients that they have other comorbidities going on. Maybe they've been battling obesity. Maybe they've been battling chronic smoking as a vice for them, high consumption of alcohol. Those patients typically, for many conditions, not just chronic pain, those patients typically have a harder time because they're really trying to change not just their chronic pain, but also something that's been affecting them for years and years and years.
While we're on the topic of, different lifestyle factors, as you know, Charlie and I are big into exercise. How does exercise play into, or just having a life full of movement, someone that's very movement oriented or participates in exercise or, is just active? Do you see that being part of their past or their health history being like a big influencer in how they do with treatment? And second question, how does exercise play in the role of progressing someone after they've been, categorized as someone with chronic pain?
So exercise definitely is a huge factor for chronic pain, or in terms of preventing chronic pain. People who are just more active when they were growing up or, any stage of their lives, they're less likely to have chronic pain, period. So that could be, for many people, that's the number one predictor about if they will suffer from chronic pain later in life. And the more you move, it doesn't necessarily have to be, long distance running or heavy weightlifting, but even just getting out and walking or going for a jog or yoga, Pilates, these types of exercise-based therapies really help prevent pain. For patients that already have chronic pain, this is something that I tell them they should be doing no matter what. And we ease into it. So if a patient isn't ready to do Pilates yet, let's start with something a lot more basic and let's just build our way up. But if the patient, like I tell patients, I can put the best injection in there. I can put the medication where it has to go. But if you're not moving around, then once the injection wears off, the pain's just going to come back. So you have to train your muscles. You have to strengthen your muscles enough to take over when the injection wears off.
Yeah. I love that you brought that up because one of the biggest pushbacks that we get from individuals when we, introduce ourselves and tell them that we do exercise and we generally work with people, over the age of 40, and they're like, well, I don't want to be a musclehead or I'm not looking to get buff, so working out is an exercise not for me. But it's so interesting how the whole health side of exercise, like how it makes you feel, how it supports your joints. And, even if you do have chronic conditions like arthritis or, a disc issue or chronic pain, that you can still find ways to exercise to still improve your health, even if you're not looking to be, sucking down protein shakes and getting huge muscles. There's a lot more to exercise than I think a lot of the population likes to acknowledge. Probably because of like social media and the press around the exercise. But I think that's really cool that you share that same view.
Well, yeah, I mean, exercise, it's more than just a physical thing, right? Like, no, you don't necessarily have to become, Dwayne "The Rock" Johnson. But even Dwayne "The Rock" Johnson will tell you that, hey, when he exercises, it clears his mind, it releases endorphins, it helps him feel better, it helps him interact better with everyone around him. So for every patient or every person like him, there's all these other patients that look and feel more like me, where I'm not Dwayne "The Rock" Johnson, but every time I exercise, it's the same way. And I'm not doing heavy lifting. I'm not running marathons. You just try to move around, and you try to, and even if it's just, shooting hoops with your friends, that's still exercise. And I think patients or people, you're right, they look at exercise with a certain notion that this means weightlifting, or this means, running long distances. But really, exercise is moving around in a healthy way.
Hey, Dr. Dave, what is the kind of average age of the patient that comes through the program with you?
It's funny you say this, because we've actually had this debate. We've never officially measured the average age. My guess is around 58. Mm-hmm. 58 years old.
Yeah, that's, I'm not surprised by that answer. I would have been surprised if you would have said something in the 40s. The reason why I'm not surprised by that is just because, kind of anecdotally, with the people that we interact with, there seems to be a clear difference in people's body tends to tolerate their lifestyle for about until really they get to about their mid-50s or so. But then it seems like if they're not putting in the time and putting in the effort to maintaining their health, between their mid-50s and their early 60s, there's like a drastic shift in how their body functions and what they're physically able to do. So I would have guessed that during that period would have been when most people started realizing, yeah, I have this chronic pain. It's just not something that's going to go away in the next week. I need to get addressed. So that doesn't surprise me at all. That being said, though, there seem to be a number of people that we interact with. You brought up this idea earlier of being in their 60s but want to feel like they're in their 20s. There's a number of people that we interact with on a regular basis that are in their mid-50s, in their early 60s and beyond, that have a ton of energy, that feel really good. Now, clearly, these are not the people that come into your program, but do you have experience, or can you speak to what things are maybe differentiating people that are feeling really good in their 60s versus not feeling as good in their 60s?
Well, you're right. Most of the time, if a patient feels really great in their 60s, they're not coming to see a pain management specialist. So we don't see a ton of that. But I would say the predicting factor is how healthy a lifestyle the person is living. So if they've been eating healthy, if they've been exercising regularly, if they have a stable home and work situation, these people typically feel better about life than someone that may not have all of those commodities. So, patients that have a lot of stress, whether it be physical due to obesity or emotional due to, family situations or work stressors, those patients are the ones that are more apt to not feeling great about certain health issues such as chronic pain. Whereas someone in their 60s, if they look and feel great and they strain their muscle, they'll say, hey, this is a muscle strain because I've had muscle strains before. I'm going to ice it. I'm going to heat it, rest for a couple days, and then it'll go away. Mm-hmm. Whereas someone that has a lot of other stuff going on and are just very stressed about any condition, they strain the muscle, they're going to focus more on it. Mm-hmm. And they're going to say, oh, this thing is lingering. It's not going away. I'm not, I don't know what to do about this. I need to go see someone. I need to get started on medication. And they just kind of actively pursue this as opposed to knowing from past experiences what muscles do or how the back acts and stuff like that.
Yeah, that's awesome. No, I really, really appreciate that perspective.
Now, we've been talking a lot about the lifestyle aspects of pain management, which is really awesome and great. And I want to jump a little bit to the medication side, because I know you brought up the opioid epidemic, and that you kind of you really have dove into that in your area of interest. What is going on with the opioid epidemic? I know you could probably talk about this for hours and hours, but in a brief idea, how does this affect people struggling with chronic pain? What are the techniques to get someone off of an opioid type drug, and what is going on in that field?
Well, the opioid epidemic it's such a vast part, or a vast condition, or vast public health phenomenon that it goes into much more than chronic pain. So, for the scope of your question, and I think this podcast, we'll focus on the chronic pain part of it. The opioid epidemic, in terms of chronic pain, has been due to the over-reliance of opioid medications for symptom management. And, back in the 70s, 80s, and 90s, there was this change in philosophy about where opioids play a role in chronic pain. Before the 70s, back in the 1900s, doctors knew that opioids were addicting, and they said, hey, we're only going to use this for wartime and what ended up being cancer-related end-of-life pain. But in the 70s, 80s, and 90s, there was this move for many different reasons beyond the spectrum of, just to keep it brief, beyond medical reasons, to push opioids into medical practice and into first-line therapies. And this happened more and more and more, and, some doctors were training other doctors who were training other doctors to make this part of first-line therapy. And the numbers just rose. There was, an exponential increase as to where now, Americans consume 80% of all the opioids in the world.
Wow.
And it's 99% of the world's hydrocodone, 80% of the world's oxycodone, and 60% of the world's hydromorphone.
Wow.
And despite all of that, what I mentioned earlier, there was no change in the amount of pain reported. So, So, we're putting all these pills out there, and patients are getting more and more pills, but they're still feeling the same. But what we did see is a very big rise in patients who were addicted to their opioids. They were dependent on them. They were addicted. They were overdosing on them, and they were just dying from opioids. So now opioids, or I should say drug overdoses, are a more common cause of death than motor vehicle accidents.
Wow.
Yeah. And I saw a stat saying that 115 Americans die every day from drug overdose, and more than 40% of that is from opioids.
Oh my gosh. Wow.
Right.
So all these people on opioids that were using them for pain are still experiencing all the same pain that they were, but now addicted to a drug potentially.
Right. Exactly. And unfortunately, patients those patients don't understand that part of it, that they're under the impression that, well, this medication helps. But so even though they'll say, oh, my pain's uncontrolled, if you say, well, then if it's uncontrolled, let's stop the opioid, it's not helping, they'll say, no, I need that. And that's not completely their fault, because that's what happens to the brain in chronic pain.
Sure.
Is there's that rewiring that happens. So, and that's what dependence and tolerance and addiction ends up being. It's not what media portrays as the person who's going around selling pills and buying pills, even though that does happen. The most common patient is the one who doesn't realize that they're addicted to their medication until they're off of it, or they run out early or something like that. So, and the challenge has been, well, the easiest solution is to say, well, let's stop prescribing opioids, right? Let's just stop giving those pills out. But what we have seen is just rapidly discontinuing opioid management has resulted in more patients going into drugs like heroin.
Oh, geez.
So we've seen an increase in heroin-related overdoses as well since the opioid epidemic has come more into light.
Wow.
And there's some crazy statistics about how many patients who are using heroin, they said they got into it from prescription opioids.
Oh my gosh, that's crazy.
That's been the challenge in terms of trying to break the stereotype that's out there, but also breaking the way of managing, like the traditional way of managing chronic pain.
Wow, that seems like a very vicious cycle in a sense.
Right. So, what the state is trying, the state and national healthcare organizations, they've really, made this a big priority for them. The state of Illinois has an overall goal of reducing opioid-related deaths by 33% in the next 3 years. So there's committees that are involved with, addressing this from a public health side, from a patient side, but also from a healthcare side, to have safer prescribing, better education, better communication between healthcare providers, and also improving access to buprenorphine and methadone, which are both very useful for patients who are suffering from opioid use disorder, formerly called opioid addiction. And then the other big response has been increasing the amount of access to naloxone, which is a rescue medication that's used by first responders to reverse the effects of opioid overdose. So that's what's happening on the public health side. And recently, on the national side, the president signed a bill to increase funding for the opioid epidemic. So, and that there's multiple aspects to where that money would go.
That's wonderful. Well, Dr. Dave, I want to shift the focus of the conversation quickly back to talking about what things you do to promote your own health. What do you do throughout your week, throughout your day to help promote your health?
Well, as long as my wife doesn't hear this, I think it'll be fine.
Don't share it with her.
So I have been an avid runner over the past, let's say, year. I really picked that up as a therapeutic goal, more for mind than I should say body. So I did do the rock and roll half marathon for the first time.
Nice.
Congrats.
That's awesome.
For the year. Yeah, now I'm taking a little break from running, from long distance running, and focusing more on body and core.
Cool.
With, try to work out about 3-4 times a week. It's probably closer to 3. And that's, these are 30-minute workouts on the weekdays, close to 45 minutes to an hour on the weekends.
I love it.
Healthy, or like dietary wise, my wife is vegetarian. I'm not, but it's been.
Are you not only when you're away from her?
She's upstairs, so I'm talking quietly right now. No, so we've really been focusing on a little bit more of a vegetarian diet to shed a couple pounds, but really with the winter months coming up, it is harder to be active.
Sure.
So we've been trying to utilize more dietary changes to make sure that my health stays the same. But one of our pain management doctors, Dr. Keith Schmidt, who works out of St. Alexis, he's actually very into nutrition. He's into ketogenic diet, so he puts himself into ketosis, for the multiple health benefits that are seen there.
Awesome.
Too. So all of us kind of have or at least in the pain clinic, we all have our little diets or exercises that we're always trying to pursue. That way we could talk to patients about it too.
I love that.
Love it. And I think it gives, a lot of validity when you, as the person suggesting changes, are also constantly trying to change and adapt to your lifestyle and adapt to the world around you. I love how you mentioned, it's winter, so you can't really get out and run. So, maybe we got to cut back and change our diet a little bit and, going with the flow. And I think that's really cool that you mentioned that and you're thinking about it in that way.
And it also, just changing things up makes things a little more exciting, right? So,
sure.
At some point, running for me became kind of monotonous until I started getting tired, and then I would just get frustrated that I was feeling tired.
Sure.
So now saying that, okay, now I'm going to do more core workout or focus on my arms a little bit. It just kind of gives you, it's a little more refreshing.
Love it. Well, Dr. Dave, what are some habits that you suggest that our listeners could start implementing to help with either, not necessarily if they're experiencing pain, but maybe to kind of prevent pain, some of those lifestyle things so they don't start to develop chronic pain?
The most important would be weight management. So making sure that, that they're very conscientious of their diet and exercise for the sole goal of preventing a lot of pressure on the spine. So when a patient is carrying weight in the anterior part of their body, so their stomach or abdomen, it will pull down on the spine, and we don't think about that. So the spine gets a lot of tension pushing it forward for years and years and years for someone who has a lot of frontal obesity. So that's the number one thing that patients can do for not just avoiding chronic pain, but also other health conditions. And that doesn't mean that you need to go on, these fad diets or anything, or have like, a stunning body. That just means, eating healthy and getting the right amount of exercise in a day to not put a lot of pressure on your spine. So outside of that, it's being active and, making sure that you're getting enough steps in a day and that you're keeping your muscles limber and loose, whether it be by stretching or yoga or any sort of movement like that. The third one is making those modifications to move your body the right way. So, when you're younger and you have to pick something up off the ground, or if you're lifting an object off the ground, you're kind of bending at the hips and you're putting pressure on the spine when you lift that object up.
Sure.
So, when you are advancing in life, let's call it, making those modifications so you keep your spine and core straight and your posture straight when you're doing certain activities can go a long way. Julie and Charlie, I'm sure you talk to your patients about, how to bend over the right way, how to adjust their posture just for pain prevention. So that's a very important part too.
I mean, that's exactly so much of what we talk about with our clients, and to hear it from another source as well, I think just makes it that more credible, because at the end of the day, like we've been talking about for a lot of this podcast, hey, either people that are in pain want to get back to doing things that they're unable to do, and one of the beautiful things about movement and about being active is it can ward off physical pain in the moment and long-term as well. So I love those suggestions. Now, Dr. Dave, how can our listeners connect with you if they feel like, hey, I'm experiencing chronic pain, I need to get enrolled in this program? How can they connect with you to either schedule some kind of consultation or assessment or to learn more?
So we have our pain management location, or we have 3 pain management locations, I should say, right now, but we are expanding. The best phone number to reach either myself or one of my colleagues, being Dr. Keith Schmidt or Dr. Mona Patel, is at 847-981-3630. And we have locations currently at Alexian Brothers in Elk Grove, St. Alexis in Hoffman Estates, and Glen Oaks Hospital.
Awesome.
In Glendale Heights. We're also expanding into a Bartlett location. That would be the best way to reach out. And otherwise, on Twitter, you can follow me at Ankur Dave MD.
Nice.
We're going to tweet you.
Definitely.
Love it.
Yeah, I don't have a lot of followers yet, so the more followers, the better.
Yeah, I love
that out there.
That's perfect.
And you could also reach out on LinkedIn. I'm under my name.
Wonderful.
Great.
We'll definitely be linking to all of those in the show notes. So, Dr. Dave, the last question that we like to wrap up with our guests is, what is your definition of health?
That's a good question. My definition of health is optimizing a patient's biological, psychological, social, and functional abilities. And that's different for everyone. So, the amount of functioning I can do with my body, or the most that I could do with my body, as well as mind, can help my overall health.
I love that. We have not heard that definition before, but I tell you what, it really vibes with what we're trying to do here with our clientele. So, I mean, you can really, really dig that definition.
Yeah, that was awesome.
Well, Dr. Dave, thank you so much for joining us. We appreciate your time. We appreciate your expertise on so many topics. And this was just an amazing, amazing conversation. Thank you for joining us.
Thank you for having me. I really appreciate it. We should do it again sometime.
Absolutely. That would be a ball. Well, hey, for our listeners, we always appreciate you tuning in, so thank you for spending your time with us. If you wouldn't mind, head on over to iTunes, leave us a rating and review, and click subscribe so next week when we come out with a brand new episode, it gets automatically downloaded to your podcast listening platform of choice. And now, who do you know that is experiencing some kind of chronic pain? Who do you know that needs to connect with Dr. Dave? Share this episode with them so they can get connected. Have a fantastic week, and we'll talk with you all next week.